Mr. Chairman, dear audience, I almost feel ashamed being here for the 7th time, and I will still come every time I'll be invited, I promise you. It's such a fantastic meeting. It's this mixture of good weather, good science, good friends, and also extremely good timing, I must say. And this year, I guess the timing is much better than any time before. I don't know why this. Okay, I will try to give you some updating of the screening trials, and of course the second slide here should show this today's publication in New England Journal of Medicine, which is an 11-year update of the ERSPC study. I will try to give you some data first, and there are of course some very strong arguments for screening for prostate cancer, and one of them is of course that prostate cancer is a really health problem in the Western world. And for example, in my country, in Sweden, 5% of all deaths among males are due to prostate cancer, and in most European countries it's around 3%. And we know that the average life length among men increases very rapidly, and as prostate cancer is so related to age, it means that more and more men will be in the risk of dying from prostate cancer in the future. And I would say that only screen-detected prostate cancer are curable. Those cancers who gives rise to symptoms very seldom could be cured. Sometimes man seeks attention because they have symptoms from the urinary tract, but it's very seldom it's the cancer that gives rise to these symptoms. So I would say if we should cure a man, we have to look for the cancer with some kind of early detection. And treatment of advanced disease has improved a lot lately, but still it only marginally increased the survival, and it is so far very costly. And the side effects from treatment, I think, has improved a lot during the last 15, 20 years. What do we know? We know about the United States and their, what we should say, population experiment from 20 years back when they have used PSA to all men, and they have a dramatic decrease in the mortality in prostate cancer. And we do not know how much of this is due to screening, but there have been some modeling from Rotterdam and others showing that probably a major effect is due to the PSA testing. But to know more about what's happening, randomized screening studies is of course much more beneficial and can tell us what happened. And there have been several such studies performed and published. 3 of them is actually from Sweden, but 2 of them are very small. The one from Stockholm and the one from Norrköping. Neither of them were actually designed to look for prostate cancer mortality, but still this one was published in BGM as a negative study, which I think is scientifically crazy. But nevertheless, this study will not give us any information about the efficacy and the harms with PSA testing. So we have to rely on the big studies, and I will shortly go through the European studies, the Guttenberg study, and I will leave most out of the PLCO study. As you know, it's a negative study, and it's a tremendous attempt to look for what an organized screening program could do in the United States, where they already had a lot of screening going on. And as you know, they have not been able to show any effect either at the first analysis or the last analysis, which came just a few months ago. And you see these curves, actually, it seems more to be higher mortality rate in the screening arm compared to the control arm. But I guess if you should do such a study, you have to have an enormous lot of men, and you can discuss the power of this study in this situation. So I will try to go more to the European studies. This was the first publication in 2009, and this was actually an interim analysis from the European study And the European study, as you know, is a study of 8 centers, but we have so far excluded France due to short follow-up. But as you can see already now, and I want to point out, there are 7 centers with quite a lot of difference in screening algorithm. You can see there is a screening interval from 2 years in Sweden, 7 years in Belgium, and 4 years in the other centers. And also, if you look on the PSA cutoff for recommending biopsies, it varies from 2.5 in Sweden and 4.0, for example, in Finland and Italy. And the age categories also differs a lot between different centers. So I think this is a strength for the ERSPC, and I will show you later on why I think this is a strength. This is a huge study, 182,000 men randomized, and in the core age group we have more than 160,000 men, and this is the first results for 3 years ago, and you can see after approximately 7 years these curves start to separate from each other, and we had a mortality rate ratio of 0.80, which means a 20% reduction in mortality in the screening group, which is a borderline significant test. If we looked on those who were actually screened, we found a 27% decrease. This should actually be the first side of the New England Journal, and I don't know if anyone didn't like that one, but it's anyway gone. This is today. It was published in New England Journal of Medicine, so it's the perfect timing, actually, very much. And this is the 11-year follow-up data. So it's a pleasure for me to present them for you here. And now you see, this is a very busy slide, but I will try to go through it with the most important findings. As you can see, in the screening group, we have 9.6% who were diagnosed with prostate cancer, compared to 6% in the control group. If we look on the risk groups distribution, you can see, if you start down here, you can see that screening very effectively decreased the risk of being diagnosed with metastatic disease. It's almost 8% here, and it's 2.6% in the screening arm, and the absolute numbers are very different. Also, high-risk disease is decreased between the groups, while, of course, those with low-risk cancer is twice as common in the screening group compared to this group. If we looked on those deaths from prostate cancer, you can see that with 299 in the screening group compared to 462 in the control group, and we divided these into 2 lengths of follow-up, and you see after 9 years we have quite a large differences. 188 in the control group dying from prostate cancer compared to 110 in the screening group. And these are the curves. Here is the control group, and this is the screening group, and you can see there seems to be an increasing gap between these curves the longer the follow-up is. If we look on the overall results, you can see that now the relative risk reduction is not very much higher, it's 21%, but the statistical power is much, much higher now with more deaths occurring. The number needed to invite has decreased from 1,400 to 1,055, and the number needed to diagnose is decreased from 48 to 37. If we just look what happened during these 2 extra years, and see what happened during these 2 years, then we can see that the relative risk reduction in these 2 years was 38% between the 2 groups, also highly statistically significant. If we look on the last follow-up and you make an adjustment for non-compliance, you can see that the relative reduction is now 29%, also highly statistically significant. And if you look on these 2 extra years, so we look on these who were attenders, we have almost 50% relative risk reduction in their risk of dying from prostate cancer. And these figures will go down with time. Now I come to an interesting part. I said before that there are differences between the centers within the ERSBC. And if we look, you can see that there are also very huge differences in the prostate cancer mortality reduction in different countries. And this could, of course, be due to differences in follow-up. Sweden has the longest follow-up and the highest relative risk reduction. But if you look at, compare, for example, the Netherlands and Finland, we have similar follow-up. You can see that the relative risk reduction is 29% in Netherlands, which also now is statistically significant in another center apart from Guttenberg. But in Finland, it's only 11%. And these are very interesting data, which will give us an opportunity in the future to analyze what is important. It's not just to screen, probably. It's how to screen, and maybe also how to treat patients. If I conclude the ERSBC for 2012, we can say that 2 extra years of follow-up consolidate our previous results. The prostate cancer mortality reduction seems to increase with longer follow-up, but it's far too early to predict when and at which level the prostate cancer mortality reduction will stabilize. And there are interesting differences between different centers, suggesting that the screening effect is influenced by several yet unknown variables. I just shortly go through the Guttenberg study, which was published 1.5 years ago. And this is a smaller study, but still powered for looking at mortality, 10,000 in each arm. When we look for, I can skip this because I'm short of time. If you look here, I think it's interesting to see, this is the control group and this is the screening group. And you can see it's not happened so very much between 9 years and 11 years. It seems to be after 11 years, this large difference between the arms happens. So I'm very eager to see what will next analysis of the whole of ERSBC will give. If we compare the Guttenberg with the PLCO, I think there are very interesting differences in a lot of different areas. But I think that this one is interesting, that despite men in Guttenberg were 5 years younger than compared to men in the PLCO study, then you would expect the mortality rate in the control group would be probably the double in the PLCO. But it's the opposite. If you look in the control group of PLCO, 0.38% of men have died from prostate cancer, compared to 0.78% in the Guttenberg study, telling us that there are very different populations we are studying. The beauty, I would say, with the Guttenberg study is that it's randomized upfront, no informed consent, but it's definitely population-based. So we could go back and look on the expected mortality from the data, from the risk of dying from prostate cancer, and create the population. And what we then see that in the control group, this dotted line is the expected mortality in prostate cancer for a group with that age distribution. And you see, despite that we have had a lot of PSA testing in later years, our control group is very closely following the expected prostate cancer mortality, which I think is telling us that the contamination so far have not disturbed the analysis. If you look on the non-attendees, they also seem to follow, while the attendees have a clear lowered mortality. We did the same with the Rotterdam study, because the Rotterdam study is where they randomize after consent. And here you see what happens. If you invite men and randomize them afterwards, their control group have a much lower mortality compared to what to be expected. So the way we randomize will give us different results in outcome, different populations. So summarize the prostate cancer in the Guttenberg study, we had a 44% reduction in the total in the screening arm, 56% among attendees, and we looked on only the younger men who are the ones who are supposed to have the best effect of screening. We found a very high reduction in mortality, but it's small numbers, so it's not easy to say. So just some discussions and reflections. Most personally, I will end up with this. I think prostate cancer screening results in a mortality reduction, at least the way we did it in Guttenburg. This is large, much larger than what we see for breast and colorectal cancer screening. And I think that the true rate of overdiagnosis is still of unknown magnitude, because it will decrease the longer the follow-up will be. But I think the largest trade-off is not really the rate of overdiagnosis. The trade-off is that if we forward the diagnosis probably 10 years, so the men, they have to live and invest in these 10 years with their side effects from treatment. And I think that is the trade-off the man should be informed about. I can skip this and just make the conclusions. The screening decreases prostate cancer mortality. Whether an organized screening is better than a non-organized screening, as it was concluded in the PLCO, I'm not really sure about that. I want to look more closely into that. And I think the harms with prostate cancer screening are considerable, but how it affects the individual vary. And I think it should be based on an individual decision if you should be PSA screened or not. The efficacy of screening seems to vary considerably between different screening programs, and as my interpretation is, it is not a question of if to screen, but how and who should be screened. Thank you.
Do you want questions at this point, or?
Yes, certainly. Are there any questions or discussions? Or I just have a question. You showed in the update of the ERSPC trial the prostate cancer mortality. Do you know the overall mortality? Is there a difference too?
I'm not really understand why people are interested in overall mortality in a screening study. There is no difference in overall mortality, and there will never ever be, because in a treatment study, you can look on overall mortality, because there you have a denominator of men who have the disease. In a screening situation, the denominator is the total population. So it's not, it must be a disease which is very, very frequent in the population if you should ever have a chance to show an overall mortality reduction. And I think no cancer will ever provide such an effect.
Well, I don't completely agree. I mean, for a patient, it doesn't make a difference, or too much of a difference, if he dies but the question is there any side effects or any harms of the treatment that follows? That's why overall survival is important, I think.
But if you look, I mean, the absolute risk reduction in the ERSPC is about 0.1%. And I mean, if you reduce the risk with 0.1%, and you should look on an overall effect, it's statistically impossible to show that. If in the future, let's say in the future that we will decrease it with 1% in absolute terms, then maybe we could show an overall, but this is not for screening trials. Overall mortality is not an interesting measure. But we have had this question from New England as well. And
but that's the main criticism. Yeah.
If you really think so, then the PLCO study now, the results of them, would propose screening, because the overall mortality of the new data in the screening arm is lower, nearly statistically significant lower than in the control arm. But the reason is that the participants in the screening arm are more healthy. So you cannot use overall mortality in a cancer which has 3 to 4% death rate.
Dr. Klotz.
The proponents of screening, of which I am one, point to the Guttenberg study as being perhaps the best case of what you can hope to expect. But if the opponents could point to the Spanish study where it's 2.15 increased risk of prostate cancer. So I just wonder, is this a question of like Bonferroni correction where you just have multiple comparisons and by chance you think you have a worse outcome, or do you have any idea how you could have increased prostate cancer mortality in a screen population?
I can tell you, we have had large discussion within ERSPC if Spain should be excluded. It's very, very few number. Is it 3 deaths in prostate cancer or something? So, I mean, it's not giving it, but we think it's better to have them in and not excluding a center because that will create more criticism. If someone asks, we can say it's 3 deaths in prostate cancer. It's meaningless to analyze, but
we must have wide. I didn't catch the confidence limits, but the confidence limits must be wide.
Yeah, extremely. I mean, so yeah.
Jonas, actually, it is in the New England. We double-checked, so it is. Great, but do you know in Guttenburg what is the contribution of the screening to the overall mortality? In other words, of course, if you would screen every single person, you can imagine what the outcome at the end would be, but at the present time, what's the contribution to the mortality of prostate cancer to people who are not in screening programs, and where actually basically you decrease by 20%, not the 4%, but actually you decrease by 20% something which is even way lower. And I don't know the answer, I'm just asking the question.
I don't know, but the absolute decrease in the Guttenberg study is from 0.9% in the control arm to 0.5%. So the absolute risk reduction in the Guttenberg study is 0.4%.
So put that another way. For every 1,000 men screened for 14 years, there's 5 guys who benefit.
Exactly.
Right? Because there's 4 guys who are still going to die, and there's 5 guys that actually benefited from the screening by not dying, and then there were about 130 who were diagnosed with cancer and maybe treated, although about a third of them, I guess, remained off treatment.
Yeah, but that's the way screening is. It's in a huge population, find people with the disease and try to find them early. So the denominator is very different in a screening situation. We always think of a treatment trial where all have prostate cancer. Then we can look on the overall mortality rate.
Okay, maybe one more question, and then Christoph Isler.
Prostate cancer is better for screening now. How could you give us some numbers about that? Because this is quite strong, and we know we need some numbers for that.
Sorry, because of lack of time, I did not give you the data. This is just in the situation, or based on the data from the Guttenberg study, where we have a relative risk reduction of 44%. If you look on the breast cancer screening trials, they are in the magnitude about 20 to 30%. I think the best one has been 37% risk reduction. If you look on the number needed to treat, we have in Guttenberg 12. Look in the core age group, it's 8. You have to treat 8 to prevent 1 prostate cancer death. If you look for breast cancer, it's about the same. It's about 10. So at least according to the data from Guttenberg, it seems more favorable to screen for prostate cancer than for breast cancer. And if you look for colorectal cancer, the decrease, at least if you have fecal blood testing, it's about 20% something in the mortality reduction. If you look on sigmoidoscopy, it's a bit better, about 35% in some studies. But it's not as high as for what we had in Guttenberg. But that's one study, and maybe you should not base it on that. But if we just look on our study, this is the results.
Okay, thank you very much.